Hi, I'm Sarah, and welcome to StemNotes, where we make academia more accessible by breaking down current papers. And today we'll be discussing the integration of technology, specifically artificial intelligence, into medicine.
And hi, I'm Eva. So join us today with Dr. Amelia Sattler from Stanford's Heart Lab to learn more about how we go about integrating AI into medicine. We'll be discussing her most recent paper, From Code to Bedside, Implementing Artificial Intelligence Using Quality Improvement Methods. This paper explores different approaches to research, particularly those that are most effective in the field of AI. These are techniques that are used on the daily by Dr. Sattler and the rest of the heart research team at Stanford.
The paper starts by emphasizing the use of quality improvement methods rather than traditional research methods in the process of integrating AI and healthcare.
This process entails first defining the problem, forming a team which is involved throughout the AI integration process, and assessing whether AI is even needed or applicable through checking for cost, model bias, and the need for model maintenance.
Then, when the AI model is actually developed, the process entails ideating on key features and possible clinical integration workflows, basically thinking about how the AI would look like when integrated with healthcare. Afterwards, researchers undergo a PDSA process. PDSA stands for Plan, Do, Study, Adjust.
Now let's go to our interview with Dr. Sattler to take a deeper dive into this process. Feel free to read the paper before the interview starts to learn more.
Yeah, so just diving deep into the paper, into the introduction, we just wanted to know, how do you predict that AI will affect the medical field?
Yeah, it's a great question. I think as as we've seen technology improve and in some ways make more complicated and in some ways make less complicated and streamline the medical field, I think that AI will follow in its footsteps. I think the determination of exactly how it will change medicine is still out there, but there are a lot of there's a huge amount of potential. I think especially as I'm just constantly reminded of the amount of information that exists in the exponential rate at which medical knowledge is growing, and how historically we've relied on a single physician or a team of physicians to have and on their individual knowledge of a specific topic in order to provide medical care, and that model becomes far less feasible as the sheer amount of information that we have grows, and utilizing artificial intelligence methodologies and technologies to make efficient and effective medical care more accessible and consistent is a huge opportunity. And that happens in a lot of different ways. There are also efficiencies that can be offered through different tools, but yeah.
Yeah, thank you so much. And I was really interested when I read your paper because I was super interested about the part of the change in research when it applies to AI. So how traditional research methods generally aren't as effective. And I was wondering if you could elaborate a little bit on that, or why they're not as effective in the field of AI.
Yeah, absolutely. Well, and I think it's, a part of it is AI, how we see it, right? So AI, with the heart team, the way that we look at bridging the gap between technology and medicine is utilizing and using a quality improvement approach, which is a problem-solving approach. So inherent to quality improvement and system change is messiness and is pragmatism and is a real world environment, because solving a problem in a lab isn't going to change lives necessarily, right? It's the first step, and it's an important step, is to prove a concept. But in order to really affect change, it has to be applicable and relevant and functional in the context of a real world environment. And typically when we think of a research environment, it's very controlled, right? So we think of randomized control trials where you have one group that's a control arm, another one's an intervention arm, and you're matching them and pairing them as much as possible and looking for these very specific differences. That's a traditional research model, but implementation science is different, and quality improvement is different, because what you're doing there is you're evaluating process measures and outcome measures in the context of a real world environment. And so for that reason, and when we look at artificial intelligence in medicine in that way, we have to adapt to the fuzziness or the messiness of the real world. And so I know that our team really believes in that strongly. And it's different. So just one other example that made me think about is that, when we think about historical kind of behind the scenes work that we do in a research lab, right? So I think, in some ways you can think of that as developing a model. So a computer scientist team or, a team develops an algorithm, a machine learning algorithm, and they develop this model, and it may work perfect on their test patients, right? Or on the test data that they have. But what we know is that one model, when you actually put it into the real world, a model can have a certain performance characteristic or a certain performance profile. But when you apply it in a different setting, it doesn't work as well. Or even if you kind of take it out of that test environment or that development environment and put it into a real world context, you have to change things, or something has to adapt to make it as high performing as it might have been in the context of when it was being developed. And so that's the gap, and that's an important gap to be aware of and to be mindful of, and something that we run across all the time, especially as that concept of developing an algorithm and then applying it to a different context becomes more widespread. So people are trying to do that all the time, because that would be amazing. So you do all this time to build this technology. How amazing would that be if you can apply it in all these different contexts and it works just as well? But what we know is that unfortunately isn't always the truth. And so we have to adapt for that, and we have to study and build tools in a way that they are a bit more able to accommodate for real life and the real world.
Thank you so much.
Yeah, definitely.
Cool. So I think expanding more on this, difference between how we're going about it as in like quality improvement versus traditional research methods. I think in the part 1 of your paper, where we start defining the problem, how does this actually differ from traditional research methodologies, or like how do they usually start, whereas how are you guys starting?
Yeah, so that's a good question. I think one way to think about it is that research starts with a hypothesis. So you have a hypothesis that you think that if you do X, Y will happen, right? And you're either proving your hypothesis or you're disproving it. And that's the whole point of a research project. Quality improvement kind of puts that on its head. And instead of having a hypothesis, the methodology actually forces you to not form a hypothesis. So one of the mantras in quality improvement is, don't jump to a solution. Don't jump to a solution before you understand the problem. And so we do a lot of work defining and learning and studying and exploring the problem and the context in which it exists. So we don't only learn about what is happening in terms of an observation. So, we can observe that, I do a lot of work with population health. So we can observe that 80% of our patients who have a diagnosis of hypertension are not well, or are well controlled, or have their hypertension in the goal range, whereas 20% of them don't. So I can observe that, and I can make a hypothesis that says, if I do this, then that will improve their blood pressure. But what quality improvement is about, and specifically that initial step of really defining a problem, is it digs into that discrepancy or the observation of a gap or a challenge or a problem in a system. So why are 20% of our patients with hypertension not well controlled? And really digging into that why before even starting to contemplate what might be a solution to that problem. So it's a respect and placing value on doing that background work before just jumping ahead. Because I think oftentimes in a lot of different contexts, it's so easy. You have a great idea. You want to just do it, right? Like I think I understand exactly why these patients who have hypertension aren't well controlled. They just, need more visits, or doctors need to know better about, or doctors need to have better access to algorithms, or whoever knows, right? You can come up with a laundry list of solutions, but until you actually understand the problem, you don't have any way of knowing what you're doing, or that the effort you're putting into solving a problem is actually working.
Yeah, of course. And then also coming into after defining the problem, you mentioned forming the team. And then just for the people listening who maybe haven't read the paper, we read a quote that we thought was really interesting in the paper, which said, many technically successful AI models are never implemented because process owners and end users are not involved until after the model is developed, preventing the operational and clinical teams from informing the design. And we thought this part of the paper was really interesting because it's something that we come across a lot. So how do you choose these members, and how do you really build a successful team that will work well together?
Great question. And I think this is one of the parts that I enjoy the most about the work, is that, as part of that kind of learning more about the problem is learning about the context in which it's existing, right? So, who are the relevant players? Like, who are the team members who have any influence on the process that you're trying to improve? So, instead of just putting a doctor and a clinic manager in a room and saying, hey, solve this problem that actually is, has to do fundamentally with a process that the medical assistants are doing, I wouldn't be able to solve that problem because I'm not living in their world every day. I could try, and a lot of the times that happens, right? You talk about things coming from a top-down approach. If there are people who don't truly understand a problem and they're trying to push solutions, it doesn't often work as well. It has its time and its place, but I would say, in terms of how to solve the problem, as you learn, or how to form a team, as you learn more about what you're trying to do, and as you go through that activity and the exercise of defining the problem that you're going to aim to solve, it's asking the question of who are the stakeholders. So who are the stakeholders, not only, who are the people who are directly involved in a process, but who are involved in the direct process and the indirect, who are being touched by that process in any way, because everybody's gonna have a perspective, and there's a lot to be learned from other people. For example, you could think of a project where you're dealing with a process that has an output, right? So an algorithm, right? So you build an algorithm. We talk about this a lot, actually. So you build an algorithm and it has an output. Who is that output actually going to, and what are they going to do with it? Because that person, not only the who is it going to, but then what are they going to do with it? Those are incredibly instrumental in the design work that goes into implementation. And if you don't think about that from the beginning, you can imagine where you could pretty easily just miss that mark. Because if you are developing an algorithm that has an output that isn't relevant to the people who need to act upon it, it's just going to fall flat, just as we kind of, describe in that quote that you brought.
Thank you.
We have examples of teams where, the computer scientists, even at academic institutions, right? You have the team of computer scientists who, maybe they observe a problem and they have a lot of data so they can build a model to learn more about it, or to solve a problem, quote unquote. But then they take it back to the clinical teams, and the clinical teams don't value the insight because maybe it's something that they could have gotten in a different way that would have been much easier, or was already apparent in the system, but the computer science team just wasn't aware of it. And so I think, again, you can prevent, everybody's energy and time is finite. Like, I wish we all had infinite amounts of time and energy, but we don't. And so how do we put really smart people in a position to get the most out of their time and energy and effort?
Yeah, that makes a lot of sense. Thank you. And moving on to the analyzing the current system and determining key features for success. So I'm just pulling from the paper again, but so it says to ensure that model and workflow design are rooted in reality, the team should perform a current system analysis. And this includes process mapping, issue identification, root cause analysis, and prioritization. These are kind of big words. So could you just like maybe break the system down for us?
Yeah, absolutely. So this is again, it's a fundamental concept of quality improvement in the sense that, once you've defined your problem and you're going in to learn more about it, it's learning about all of the different aspects. So we can go back to that hypertension example. So say we have 20% of people who have high blood pressure that are not well controlled. So we look in and we dig into that 20% of people, and we learn more about what their experience is. We learn more about what the structures and processes are to help bridge or help bring their blood pressure under control. You can imagine where you might there's a process of that whole process of digging into it can be a current state analysis, right? So and then the process mapping is the activity of writing it down. So it's having a shared consensus, whether that's a document. We used to do with sticky notes, but now that everything's virtual, we do it virtually. But coming up with a shared understanding that's written down of the current steps or the current process and the steps that are involved and the people who are involved in the process. And then you do, then you go and you observe and you see where the potential gaps are, right? So, and doing that can happen, in medicine, we talk a lot about doing chart reviews, we do, case reviews. You can actually, and ideally, you would actually just go to the environment where a problem was occurring. So say we identified that, one of the problems, and this has happened to us, so one of the problems was with blood pressure measurement when patients came into the clinic. What does that process look like? And, you can imagine, so, we observe a medical assistant rooming a patient and they're being rushed through it because everybody's in a hurry. And then we're taking their blood pressure, and we know that anxiety and feeling rushed can make your blood pressure go up falsely. And so identifying that only happens if you're observing and you've you're taking the time to document and look at some of the root causes or some of the potential causes that are leading to the problem. The idea of prioritizing them, that one I think is really important and sometimes overlooked, which is that, as a project, and you might see something happen, right? So say one time a patient comes in and they had a poor blood pressure reading because they had gotten in a car accident and they were crying and they were really upset. And we took their blood pressure and it was sky high, right? That happened once, and maybe we did 50 observations or 20 observations. We can't solve for that one time experience, right? We're not going to be able to solve for people who come in having had a life-threatening event or something that's incredibly stressful that's going to falsely elevate their blood pressure temporarily. We're not going to put our effort into solving that problem. What we're probably going to put our effort into solving the problem is that, say, of those observations, 15 times we realized that the patient had an elevated blood pressure reading or an inaccurate blood pressure reading for a reason we could control. So maybe they were rushed into the visit. We didn't allow them to sit. Maybe the medical assistant, there was something with the medical assistant protocol that wasn't ideal. So maybe they, didn't, they had them check their blood pressure with their legs hanging over their chair when their back is supposed to be well supported and their legs are supposed to be well supported. Like, are there education opportunities or training opportunities that we can identify that would affect a lot more people? So you can say you train one, or you educate or up train one medical assistant, and that might affect the blood pressure readings of 50 patients a day, right? And that effort and time is going to be better spent and more effectively spent than focusing on the one-offs, right? So the one-off things. And that's the process of prioritization, which is looking at, of the problems that you've identified or of the gaps in the system that you've identified, which of them happens most often? And you don't only prioritize based on frequency, but that's just one example of how you can prioritize. We talk about quick wins. So if there's something that's a really quick win and maybe it affects a minority of the population, but the effort to solve it is really quite low, do it, right? You've solved the problem, you're fine. And maybe there's a more involved solution that would affect a lot of people. But maybe it's worth it because ultimately, if you get it up and running, it won't require as much effort on behalf of the team, and it'll save people time and solve the problem.
Yeah, thank you so much for that explanation. And then continuing on to some of the bigger terms, so the ones we just talked about, and then later on, where in the next part of the paper, we talk about assessing where AI is needed. You talk about just pulling from the paper, the potential for model bias influenced by the ability to procure a population representative data set and the extent to which inherent biases can be mitigated. And so throughout the paper, you talk about this whole thing of biases and model bias. And since that's a more complicated term that we don't hear in our everyday discussions, could you explain a bit more about what model bias is and how it happens?
Yeah, absolutely. So in the world of artificial intelligence and this idea of, computers coming to these hypotheses and like making these conclusions, we talk a lot about ethical development or responsible AI. And what that means is that when we're training a computer model or when we're building this technology, we're responsible for the data in which we're using to train the tool, because it's like bias in is going to be bias out. And that's one of the questions and concerns that a lot of people have about widespread use of artificial intelligence, which is that for the populations who are not as effectively represented, the computer is going to be making conclusions based on a smaller sample of data, right? I was just thinking about an example that I learned about in some of the depression screening work. So we're working on automated depression screening for our primary care patients. And one example, it was a paper that was published recently, but they were talking about how they were comparing their paper-based processes. So they were comparing, I believe it was physician screening patients for depression versus medical assistant screening patients for depression. And what they found was that when you take it out of the hands of a physician, you get a broader sample, or you get and you make it more kind of just part of your standard work protocol, it's more likely to happen more systematically, which makes sense, right? So as a physician, I have 50 things I want to talk to, or as a primary care physician, I have, a laundry list of things I want to talk to my patient about. I'm probably only going to screen them for depression if I have any reason to believe that they might be depressed, right? So if I'm going to prioritize, it comes in that kind of laundry list if it's left on my plate to do. And what they saw, understandably, or for whatever reason, was that there were discrepancies. So, certain genders were screened more often, certain ethnicities were screened more often, X, Y, or Z happened, right, in the context of the physician screening as opposed to the medical assistants. The medical assistants did a better job at screening a broader population because it was part of what they were supposed to be doing for every patient. However, they found that even medical assistants, there was an unconscious bias of which patients they were screening. So there were still gaps in the patients who were left unscreened, even though it was part of their standard work that they were supposed to do for every patient. There's still a human factor in that process. And it led some people to feel uncomfortable or, to not screen certain patients. And so you put computers on top of that. And I think it illustrates an opportunity where you can actually help to eliminate or to reduce bias. Because if you put a computer in place of that medical assistant, who's already better than the physician, but you put a computer in place of the medical assistant, that is different. So it's not to say you're going to catch everybody. However, you're going to get a higher reliability across your entire sample that's much less likely to be biased for some of the things that we see biased around right now in human processes. So I do, with that said, I'm not saying that the AI, you have tech literacy and other, problems of interacting with technology, and that kind of comes with its own problem. But problems. But at least I see that as a huge potential, especially as our technology tools become more accessible and become available more commonly in a variety of languages. It just has the ability to scale up in that way so much faster than we can do with human processes. And there's an inefficiency that can actually, I think, has the potential to counteract bias if we're thoughtful about it.
Cool. Thank you so much. That's a really good example. And I actually didn't even know that before. So that's really cool or interesting to know.
Yeah.
Cool. So moving on to part 2, concurrent with AI model development. I just wanted to discuss the process of ideating on key features and possible clinical integration workflows. So again, pulling from the paper, I just have this quote: some of the most helpful tools for AI implementation are future state process mapping, applying lenses, prototyping, body storming, and design simulation. And I've heard of a few of these phrases before, but obviously some of them are very new to me. And I think that it'd be really interesting if you could just like maybe take us through what this process like looks like.
Yeah, we're actually going through it with a project that we're working on right now, which is, we're working with a computer science team who are going to develop a model. And that's the first phase, is getting them the data so that they can train the model and develop an algorithm. And then what we have to do at the same time, right? So we've kind of identified the problem, we found the gap, we have a team who's going to help us develop a solution that we think will be helpful. But then again, we have to, at the same time as they're developing the model, we have to start thinking really clearly about how we want to implement the solution in the context of clinical care. And so oftentimes what that means is piloting with a non-technology solution. So there are huge costs to integrating new technologies in healthcare. I mean, in any system, right? But I think, again, having the most experience with healthcare, when you think about electronic medical records, they're incredibly complex. They're oftentimes individualized to a certain system. And so when you layer on or you put in a new technology on top of it, it has a huge cost both to the people and to the system. And so they don't do it lightly. And so when we think about this work, what we're considering right now is not looking. So we did this process mapping for the current state, and we did a current state analysis for the problem to identify the problem, but then applying some of those same tools to look at and design and build out what a future state could look like. So bridging what was to what could be, and doing that with the development of the technology in mind. So, for example, who are the people who are currently, like, kind of going back to that current state process map and saying, who are the current state analysis, and saying, who are the people who are currently receiving the information? And thinking about the future and thinking, all right, so are we changing the information that's going to be sent? Like, are we bypassing, layers of people completely, which is fine. Are we able to skip ahead and actually skip ahead to a next line of communication? And if so, who are those people? How do we access them? What information do they need, and who are they going to be communicating it to? And until you sit down and really draw out, and again, it's about documentation and having a shared visual and a shared understanding of what that can look like. Until you've done that, you can't appreciate all of the detail. And so I would say that future state design process rests a lot on the previous work of current state analysis. But it involves, as you can imagine, it involves a bit more creativity and a little bit more ideation, but then also pilot testing. So, looking at what we think we want an output to be, how do we simulate that without technology? So how do we simulate that with a paper-based program or a page alert or some other system that currently exists, but something else that currently exists in our system, a message, or X, Y, or Z, whatever is relevant to the solution that you're developing. But how do we mock it up in a way that we can pilot it so that we can identify the gaps before it comes time to do a true full implementation? And I would say in all of the work that I do, we always pilot test. So we find a small sample that's, potentially, hopefully representative of what the larger population looks like in terms of the people who are going to be involved in the process, and troubleshoot it. and we say fail fast and fail quickly and then move on. How do we identify where the sticking points are going to be so that we can implement or integrate that learning into the solution, so into the model development if we need to, as soon as possible, because that's a lot easier to do in the beginning than it is at the end. But oftentimes you can't do all of that work until you have some idea of what's going to be technologically feasible. So you can't do future state, design completely until it has to happen. I guess so that all that's to say is it has to kind of all be happening sort of at the same time, or I think in a perfect world happening at the same time, because once that technology is developed, you also want to be able to have a pilot planned out so that you can test it out and learn about what's going to be necessary for implementation you might not have been able to anticipate prior to the project.
Thank you so much. That was really helpful. And I really understand. The terms are more understandable now.
Oh, good.
So then I just wanted to talk about the next part in part 2, which is I found it a really interesting idea of the PDSA plan, which stands for the Plan, Do, Study, and Adjust. And I was just wondering, why is it generally more effective than traditional research methods? And could you take us through maybe each step so we can gain a better understanding?
Absolutely. And I think, again, I would say it's more effective than traditional research for this line of, or for the specific projects that we're working on, which is when you're talking about the step of implementation. So for example, research studies take a long time. And so it has to be very controlled. So you can only test one thing at a time or a couple things at a time, right? Because you want to keep the environment as controlled as possible so that you can statistically determine whether or not your thing, whatever you're testing, is going to make a difference. Implementation is much different, right? So we can implement and we can integrate multiple tests of change at the same time. And as long as we're tracking our metric along the way and we're mapping when we introduce a new intervention, we should be able to pretty clearly identify which of the interventions led to improvement. But I would say in quality improvement, we take much more of like a shotgun approach in the sense of like, test it, just get it on the ground, test it. And that's where the PDSA cycles come in, right? So planning is all of that work that we've done to get to the point where we understand the problem, we understand what's leading to the problem, and we've identified a couple of aspects of the problem that we think we can solve that are worth our effort and our time. And then we've done all this planning. And then you do it. So then you just do it. You put it out there. You designed a solution that you think based on all of your work, not just because you think it's a good idea, but you think because of all of the research and all of the work that you've done that it's plausible that this intervention is going to lead to change, a favorable change. So then you do it, you implement it, and then you study it. So you have to learn. So you have to watch, instead of, in a lot of research studies, the data is hidden and it's buried and you don't look at it until you've done the study because you don't want to bias anything about the work that you're doing. In quality improvement, we watch the data the whole entire time. We watch it all along the way because we're looking for any signal of change. And when we see that, we jump on it and then we try to enhance the solutions that we think led to that improvement. And so it's very iterative. And that's where, again, so you've planned, you've done it, you've studied what you're doing. Say it doesn't work. That's also really interesting. So why didn't it work? And I don't want to have to study this for a year and a half to know that it didn't work. I only want to look at this for a couple of weeks or maybe a couple of months, depending on the intervention or kind of the scope of your project. I only want to look at it for a little bit of time and then I'm going to adjust it, because if I think it should work, there's something in there, like you've done the work. So there's something about it that should work or that you can learn from. And so it's asking why. So I think I did a lot of work to figure out that this should probably help, and it's not. So why not? Why isn't it working? So then you go back into that you go back into that adjustment phase or that iterative phase, or that adaptation phase where you're learning from the process as you're trying to change it, and you're figuring out what it is now, not about the process, but about the intervention that you put into place that isn't working like you thought it should, because it probably should. That's the cool part about the work is that you put in the time and the effort to be able to have outcomes. And so you want to see and not learn why. And that it's such a fun process of going in and saying like, oh, okay, all right, well, this is working, but maybe not as effectively as I thought it was going to. Like, what's missing? And oftentimes it's just something little. It's something you didn't anticipate or you couldn't have anticipated until you actually saw it in real life. And that's where for certain types of solutions, you gain so much by being able to do that in real time, as opposed to having to wait for a full research cycle to look at the data and then potentially realize that what you had done, there was something that was off and you needed it to be a little bit different, but now you have to go all the way back to the beginning and do a whole nother trial and control everything around it, right? It just isn't as flexible, and it doesn't allow for real world variation in the same way as can be useful in implementation. Again, there's definitely a time and a place for research, a lot of it, but just, we find this to be more effective for the projects that we're doing.
Well, thank you so much for that explanation. And just to end it all off, how do you foresee these research methods, so like this quality improvement, I think, emphasis research methods being applied to other fields beyond AI?
Well, yeah, so quality improvement actually, it started in aerospace. Like, it started in the airline industry or in the automobile industry. So in the industry of automation and mass production, or in these processes and procedures that either, like in the airline industry, have dire consequences, right? In terms of plane crashes or plane malfunctions. And then also in organized manufacturing context. So we think about like Toyota in Japan as a huge example of quality improvement. And it's, again, it's an engineering concept that we've applied, and I think can be applied really broadly. And when you say, thinking about that question of where else can we, I think we've adopted it in medicine, and certainly in engineering and technology. I think it's the scope of the people who are using it is pretty widespread. But then, we talk about, one of the classes in the medical school teaches quality improvement by having the students come up with a personal improvement project. A lot of the work that I do is applicable to everyday life. Like, how do you make change, and how do you affect your life in a way that helps you reach a goal? And it's a different way of thinking about that, and a different way of working towards that. And that can be applied across, I would say, almost, any context, really. I think there's a role for an improvement mindset in many, many, many things, if not everything. That's broad.
Thank you.
Broad brush.
Thank you so much for this. It was really helpful, and I really enjoyed learning more about your paper and how all of these questions are applied to the field of medicine, but also outside. And so thank you so much for coming today.
Oh, happily. Thank you so much for having me.
Thank you.
Thanks to Dr. Sattler. That was super interesting. I really enjoyed learning about these new methods, on how to research better and how to make a plan more effective. And I really look forward to seeing these integrated in the field of medicine, hopefully soon.
Again, thank you so much to Dr. Sattler for agreeing to interview with us. If you would like to interview with us about any of your papers, feel free to send us a message on the StemNotes website. And if you enjoyed this interview, feel free to check out any of our other interviews, as well as our blog posts. We're dedicated to breaking down science into simpler terms to create better education for everyone.
Thank you so much.